السلام عليكم.
وعليكم السلام.
Good evening, everyone. Good afternoon, sorry. I am Amjad Barnawi speaking. I'll be the moderator today, inshallah. Unfortunately, Dr. Nof, maybe she will not be joining. Okay, today we're gonna speak first of all about stintless and replacement of aortic root replacement by Dr. Agada, but we'll just wait maybe 5 or 10 minutes, even me in my way, inshallah, to home. So let's just wait the guys to group at 10 minutes and then we'll start, okay?
Okay.
Dr. Agada, any consultants you contact, so he will be supervised the session? Or
Unfortunately, no, because my lecture is postponed. The last session I prepared with Dr. Hussein Al-Amoudi, but that time, unfortunately, no.
okay, we'll see the rest. Okay. دكتورة غادة.
Yes. Can I start?
Still the number actually. I prefer to wait for more 5 minutes. What do you think? Still the number is barely the half.
Okay, no problem. We can
We'll wait
start.
just for more 5 minutes, and then if they're still the same, we'll start. Okay.
Okay.
Thank you.
السلام عليكم.
وعليكم السلام.
غادة، معاكم أحد كونسلتنت اليوم؟
لا والله للأسف لا.
طيب I'll try to be there from time to time. شكرا.
يعطيك العافية.
السلام عليكم دكتور فريد.
أيوة، السلام عليكم ورحمة الله. ما أدري مين كان زاهم علي.
ايوه انا امجد. دكتور فريد كيف حالك؟ الله يعطيك العافيه.
هلا، الله يحييك. الله يحييك.
الله يكرمك. ايوه انا اليوم ان شاء الله حكون المودريتور، بس نحن كنا منتظرين انه العدد شويه يرتفع. بس بما انك الله يعطيك العافيه موجود، ممكن اذا حاب نبدا.
يا أنا أشوف
أوكي.
عادة إذا تبدأوا في الوقت دائما، واللي يفوتوا الطيارة تفوتوا الطيارة، ما حيقابل أمل.
مظبوط
Okay.
طيب خلاص اتفضل يا دكتورة غادة.
Assalamu alaikum. How are you, everybody? I am Ghada Al-Harbi, R5 from Medina Cardiac Center. Today I will present the stentless aortic valve replacement and root replacement. My objective regarding the aortic root anatomy, types of the prosthetic valve, stentless aortic valve with advantage and disadvantage, operative techniques of the stentless aortic valve, indication for aortic root replacement, and operative choices for aortic root replacement. Starting about the aortic root anatomy, the aortic root is represented the outflow tract from the left ventricle, extended from the basal attachment to the leaflet within the left ventricle to the sinotubular junction. It contains the aortic annulus and aortic valve, sinuses of the valsalva, and the junctions. With first junction, the sinotubular junction, seen here in the picture, between the distal part of the sinuses and the proximal part of the ascending aorta. Also, we see the ventricular arterial junction between the aortic sinuses and the ventricular myocardium, and also the basal ring that join the inferior aspect of the valve leaflet. Going to the prosthetic type of the prosthetic valves, either mechanical or biological. Mechanical, like a bileaflet centroid valve, showing in the picture A, single tilting disc, Medtronic hole showing in picture B, cage pole, Star Edward showing in the picture C. In the last session, we come in the detail across all mechanical valves. Biological valve, subclassified into stented valve and stentless valve. Stented valve, like a porcine xenograft mosaic, showing in the picture D, and pericardial xenograft magna, showing in the picture E, and stentless valve, like a porcine xenograft freestyle, in the picture F, and pericardial xenograft. Here we have a picture of the stentless bioprosthetic valve, the Serene Freedom and Medtronic Freestyle, Edward Prima Plus, and Centrude Torrento. We have types of the stentless valves. We have 3 generations from the stentless valve. The first generation is Prima valve and Freestyle valve, Torrento stentless porcine valve. Second generation, which is Schillhai super stentless aortic porcine valve. And third generation, which is Buffen Serene pericardium and ATS3F heart valve. The available prostheses in the stentless valve, we have many stentless xenograft valve come and goes in the market over the past, but currently the only 2 stentless available valve is Medtronic, porcine Medtronic Freestyle and ATS3F valve. Starting by Medtronic Freestyle, it's showing in the picture here. The valve began clinically application in the early 1990s. The valve followed closely behind the development of Centrude Torrento stentless porcine valve, which is now out of the production. It had several options of the implantation techniques similar to the homograft, include full root or root inclusion and subcoronary position. The Freestyle is complete porcine root with minimal polyester fabric covering all exposed porcine myocardium, like it's showing in the picture down. The Freestyle bioprosthesis is treated with alpha aminoolic acid, designed to mitigate both leaflet and wall calcification. Minimal long-term human data exist of the effectiveness of this perioperative anti-calcification treatment, Also, the group at Harfield recently reported lower calcium score in the freestyle valves compared with the homograft at 8 years. Second valve, which is ATS 3F valve. The valve is designed as tubular structure and constructed from the 3 equal sections of the equine pericardium, with each section cut roughly in the shape of the square. The choice of the equine pericardium is reportedly based on its strength in the area of the leaflet where stress was found to be greatest, and also the equine pericardium thinner and more consistent in the thickness compared with the bovine pericardium. It fixed with the 0.25% preferred glutaldehyde to preserve its collagen matrix and reduce its immunological and thrombogenic potential while preserving its the strength and flexibility. And in this valve, the anti-calcification agent are not used. The proximal orifice of the ATS valve has been attached to thin polyester swing ring used to attach to the bioprosthesis to the aortic root orifice, and the distal portion of the valve has 3 commissural tabs formed from the contiguous section of each of the leaflet and reinforcing polyester material that are used to attach the commissures to the native aortic wall. The tubular design of the valve allows the omission of the full subcoronary suture line, and 3 commissures are attached to the aorta at 120 degree spacing at appropriate height from the annulus. Currently, little data exists on the performance of the 3F valve, although at 1 year in a study of 35 implants, mean gradient ranging from 9 to 13 millimeter mercury, there was minimal aortic insufficiency and no structural deterioration. Here we have a comparison of the mechanical and tissue valve in the aortic valve replacement regarding the advantage and disadvantage. In the mechanical valve, it's long durability and good effective orifice area with easy implantation, with disadvantage of use of anticoagulant and risk of the bleeding. In the stented bioprosthesis, it's easy implanted, but with no anticoagulant use, but the durability is limited and poor effective orifice area. A stentless valve, it's larger effective orifice area compared with the stented bioprosthesis, and root replacement is available option. The durability is limited and it's complex operation and complex reoperation. Regarding the allograft and autograft, they have the excellent effective orifice area and good choice for endocarditis, but in the allograft, there is limitation of the availability, durability with complex operation in both allograft and autograft. Going for indication of the stentless porcine xenograft and aortic homograft, stentless valve conduits such as porcine root or aortic homograft have advantage of the AVR with the stentless valve conduit, lower transperipheral gradient, possibly enhanced regression of the left ventricular mass, low risk of the thromboembolism without the need for systemic anticoagulation, low risk of the prosthetic valve injection, but these conduits are subject to the structural deterioration. Also in the indication, the strongest indication for homograft is for treatment of the active aortic valve endocarditis, particularly in patients with the root abscesses, fistula formation, or prosthetic valve infection. The porcine root is also an option in aortic valve endocarditis with root destruction, requiring a root replacement with the advantage that it possesses the minimal prosthetic material compared with the polyester valve conduit graft. The stentless porcine root and aortic homograft are also reasonable option in older patients older than 60 years of age with a small aortic root. The aortic homograft can be considered for younger patients requiring composite aortic valve or root replacement who cannot be anticoagulated. Preoperative evaluation. Transthoracic is a valuable diagnostic tool for evaluation of the aortic valve and associated anatomical structures. CT angio or cardiac MR imaging can also be very useful in evaluation of the potential homograft patient, particularly those with aortic root abscesses. Coronary angiography should be employed with the standard indication, but may be hazardous in patients with the mobile vegetation on the aortic leaflet. Standard CT chest with or without contrast should be considered in any reoperative patient. Transesophageal echo is often necessary to establish the presence of the aortic root abscesses, but the major role is intraoperatively. Operative technique, general preparation, tender midline sternotomy incision provides full exposure of the heart. Routine distal aortic cannulation and diastolic venous cannulation can usually be employed unless circulatory arrest is needed. Minimal systemic cooling, 32% is adequate. Combination of antegrade and retrograde cold blood cardioplegia. Transverse aortotomy is made high, 1.5 to 2 centimeters above the commissures is usually best. The diseased aortic valve is excised and the annulus is measured with the cylindrical sizer. If using the porcine route, the size can be confirmed and the prosthesis open and rinsed. If using the homograft, sufficient time, about 20 minutes, is required to thaw the prosthesis, and so a decision to use the homograft with a specific size is required prior to exposing the root and sizing it directly. Going to the operative technique, started by the first technique, which is modified subcoronary implantation. In this technique, we will do like in the first picture, transverse aortotomy is made 10 to 15 millimeter above the origin of the right coronary artery, slightly above the sinotubular junction, and the incision is extended 3/4 of the way around the aorta, allowing good visualization of the aortic valve and annulus. Tack back the ascending aorta for visualization of the aortic root and any pathology. Then, like in the second picture, we see the placing the suture through the commissure if desired for the good exposure. Going for site preparation. After completely excise the diseased aortic valve and debride the aortic annulus and the aortic wall of the calcium, we have to localize the patient left and right commissure and use it as a point of the implantation. Then we'll go to the size the valve, and the sizer should be fitted to the plane of the implantation, which is the lowest level of the aortic annulus, the nadir. And the sizer need not pass through the annulus into the LVOT. So choose the largest size that will be seated on the nadir of the 3 cusp without impeding the sinus tissue. Then, preparing for inflow suture line, we will use the patient left and to right commissure as a point of the origin to correctly implant the freestyle bioprosthesis, starting by 2O polyester suture in the horizontal plane of the level of the nadir of the annulus. Suture should be in subcommissural area between below the left and right commissure, and in the fibrous tissue and valve tissue between the right and non-coronary commissure and left to non-coronary commissure. And the suture passed in the muscle below the left and right commissure should be genius, right, as this muscles is and tissue is very friable. Then we'll trimming the freestyle bioprosthesis. But prior to the trimming the bioprosthesis, it's important to determine whether the freestyle can be implanted with the freestyle coronary sinuses corresponding anatomically to the patient's sinuses, or will be necessary to rotate the valve. If the decision was to rotate the valve, we have to the left and right sinuses of the valve will be excised with leaving 1 to 2 millimeter margin of the freestyle aortic wall along the leaflet tissue to allow adequate suturing. After that, we're seating the freestyle bioprosthesis, starting at the right and left commissure. Will divide the suture into equal thirds. The first stitch in each third will be pass through the inflow suture cuff of the freestyle and points corresponding to the bioprosthetic commissure. Then the remnant suture will be passed efficiently into the bioprosthetic swing cuff, being tied the non-coronary sinuses. And see in the last picture, when placing the stitch through the swing cuff, we don't complete pass the needle through the cuff until all suture between the two commissures have been inserted and even spacing is confirmed. Then after seating the valve, going to outflow suture line. In the outflow suture line, by running technique with double arm 4/0 polypropylene stitch, we begin the suture at the left coronary sinuses, like in the first picture. Then run the suture in subostial up to the top of the left to non-coronary commissure. Then complete the suture line to the top of the left and right commissure, like in second picture. And in third picture, we see the running suture to complete the suture line underneath the right coronary ostia. This is for subcoronary implantation technique. Going for second technique, which is inclusion homograft cylindrical inclusion root technique. In first picture, we see that we trim the bioprosthesis for in the inclusion technique. So the left and right coronary sinuses are excised. The proximal line are placed as in the previous subcoronary method, same technique. And we see in second picture, the excised coronary sinuses of the prosthesis swing to the native sinus wall around the coronary ostia using continuum 5/0 Prolene stitch. Then in last picture, we see the coronary artery coronaries are secured and distal end of the homograft attached at the commissure and then incorporate in the aortotomy closure. Going for the third technique, which is full root replacement. We can see in the first picture, the replacement begin by the complete transection of the aorta about 3 millimeters above the sinotubular junction. Then in second picture, we see the coronary arteries are mobilized with genius bottoms of aorta with a traction suture on the top of the bottom to help to maintain the orientation. Then going for sizing of the valve. After removing the tissue of the sinuses of the Valsalva and diseased aortic valve, the valve will be sized after identifying the largest size that will pass into the left ventricle cavity, and which the valve chosen should be one size larger valve, so will the internal orifice of the valve will match the left ventricle outflow tract diameter. Here we see the suturing of 3O double-armed polyester suture placed in the simple fashion through the left ventricle tract with the felt strip to help the hemostasis. Then in the second picture, the coronary button swung to the bioprosthesis using running 5O monofilament suture and taking care to maintain the proper orientation. Finally, the native ascending aorta and vascular graft will be trimmed to appropriate level, and end-to-end anastomosis is made using running monofilament suture. Here with the results of the homograft with inpatient without active endocarditis at the time of the surgery, operative mortality from 1 to 5%. The ischemic time for aortic root replacement, either stentless porcine or aortic homograft, is approximately 90 minutes. Patient with the active endocarditis exhibit a higher early mortality ranging from the 8 to 16, with more percentage in the prostatic valve endocarditis from 17.9 to 18.8, comparing with the native infective endocarditis, which is from 2.6 to 10%. The other complication, like a hemorrhage, heart block, stroke, myocardial infarction, and wound complication, occur with the similar frequency to those with other aortic root replacement, but early risk of the endocarditis is lower with the homograft than any other replacement valve. The long-term outcome in the homograft, the long-term durability was compromised by the young age of recipient, to the point that patient under 20 years of age had 47 rate of the reoperation, but patient over 60 years had 97 freedom from the reoperation at 15 years, while between the 21 to 60 had 81 to 85 freedom from the reoperation at 15 years. Regarding the structural valve failure of the hemograft, at 10 years, it's 90 to 38%, and at 20 years, it's 69 to 82%. The freedom from the endocarditis at 10 years from 93 to 98%, and at 20 years from the 89 to 95%. While the freedom from the thromboembolism at 15 years is 92, and at 20 years is 83. Going for the porcine root result, the preoperative outcome, operative mortality ranged between 1.8 and 9.6, but with most experienced center reporting operative mortality around 3 to 5%. Many of series that report their mortality outcome include patients who receive concomitant coronary bypass or other valve surgery at the time of the freestyle root implantation, making it difficult to compare this outcome to the isolated aortic valve replacement or isolated biopental result. Hemodynamics and durability of the Medtronic Freestyle. The Freestyle stentless valve is often selected for its superior hemodynamic performance that have been demonstrated in multiple series and meta-analysis of 919 patients by Canadian and College demonstrate that compared with the stented valve, the Freestyle have a larger effective orifice area index and lower transvalvular gradient with more rapid rate of the left ventricular mass regression in the freestyle valve patients. Here we have a study of midterm outcome of the stented versus stentless bioprosthetic valve after aortic root replacement. This study to determine the impact of the aortic root replacement with the stentless bioprosthetic valve on midterm outcome compared to the stented bioprosthetic valve graft. It's the observational study of the aortic root replacement from 2010 to 2018. All patients with the complete aortic root replacement for non-endocarditis reason were included, while patients undergoing valve-sparing root replacement or primary aortic valve replacement or repair were excluded. Bioprosthetic valve implants were included, while mechanical valve implants were excluded. We see here the total number of the 555 patients after excluding the patient with the mechanical valve sparing replacement technique and endocarditis cases. A total number of 455 patients underwent complete aortic root replacement with bioprosthetic valve for non-endocarditis reason, with 212 patients going for stented bioprosthetic aortic root replacement, while 243 patients with stentless bioprosthetic aortic root replacement. In this table, we see the post-operative outcome comparing the matched and non-match or before matching stented valve group versus the stentless valve group. For the matched cohort, we can see the operative mortality in the stentless valve group, 7.6, was similar to the stented group, which is 9%, which is 9. But we can see the prolonged ventilation for more than 24 hours. It's more likely to be prolonged with stentless patient, which is 26.9, and compared to the stented patient, which is 15.2. But regarding the other post-operative outcome, which is adverse neurological event, stroke or TIA, sepsis, and new dialysis requirement and re-exploration for bleeding, was similar across each group. Here we compare the longitudinal echocardiography data between stented and stentless group at 1 month and at 1 year. At 1 month follow-up, the residual aortic regurg more than or equal to plus, as well as the ejection fraction, was similar across each group. And also in 1 year, the residual aortic regurg and ejection fraction were similar in each group. But we can see the peak aortic valve velocity lower in stentless group, which is 1.6 plus minus 0.5, and compared with the stented group, which is 2.1 plus minus 0.6. Also in the mean aortic valve pressure gradient, in the stentless group, it's lower than the stented group. In the stentless group, it's 6.3 plus minus 4, but in the stented group, it's 10.6 plus minus 8.1. Also, the peak aortic pressure gradient is lower in the stentless group, 11.4 in compared with the stented group, which is 19.1. We see also here the Kaplan comparing curve comparing the survival by year between the stented and stentless valve. After matching, we can see in the 1 year, the survival in the stented group, it's about 85%. And in the stentless group, it's also about 84%. While in the 5 years survival, the survival in the stented group is about 69, while in the stentless group, it's about 72. So the Kaplan curve demonstrates the survival between the two groups. There is no difference between matched stentless valve and stented valve at p-value of 0.5. In conclusion, this study suggested that aortic root replacement with the stentless bioprosthetic valves can be safely performed given similar short-term morbidity and mortality with a stented bioprosthetic valve graft conjugate. At 1 year follow-up, the stentless valve group had significantly lower aortic valve velocity and pressure gradient compared to the stented valve group. However, in midterm, the stentless valves were not associated with improved survival or reduced rate of reoperation. By implication, the stentless valve may provide hemodynamically benefits after aortic root replacement, but the clinical impact of this benefit may not be evident in the midterm. We'll talk about now the pulmonary autograft, which is Ross procedure. Theoretical consideration, the pulmonary autograft share the hemodynamics advantage and antithrombotic feature of the homograft, but it's the only valve which has the benefit of being fully viable autologous tissue. Pulmonary leaflets have been found to have equivalent breaking strain to the aortic leaflet and even higher tensile strength. The initial response of the pulmonary valve is to lay down a collagen-rich support on the ventricular aspect of the leaflet. This thin out later, but remains slightly thicker than normal aortic leaflet. All 3 layers of the pulmonary leaflet, fibrosa, spondylosa, and ventricularis, contain viable cells which maintain a rich extracellular matrix to support the leaflet function. Endothelial cells are transformed to become capable of the smooth muscle actin protection and becoming more like the aortic than the pulmonary phenotypes. Patient selection for Ross procedure. The cardinal principle in selecting patient for Ross procedure is that they must have life expectancy of at least 20 to 25 years. Some conditions often limit the life expectancy and also influence the ability of the patient to withstand this longer procedure, like poor left ventricular function, multi-vessel coronary disease, and need for complex mitral repair. The ideal patient is under 15 years of age, but special circumference can extend this to 65 or even slightly higher. Patient with the active lifestyle, potential for childbearing, and contraindication to anticoagulant favor the Ross. The generally accepted contraindication are significantly pulmonary valve disease, congenitally abnormal pulmonary valves, Marfan syndrome, other connective tissue disorder, complex coronary anomalies, and probably severe coexisting autoimmune disease, particularly if it's the cause of the aortic valve disease. Active rheumatic disease is a relative contraindication, as the autograft can be attacked early by the acute rheumatic process and lead to the early failure. Bacterial endocarditis is not a contraindication for Ross procedure, So it's the best use when only leaflet destruction is present, or when the root involvement can be reconstructed without distortion. Ascending aortic dilatation and aneurysm have been considered contraindication by some, but this can be easily addressed. Previous AVR or other open cardiac operation are not a contraindication to the ROS, but all the standard consideration of the reoperative surgery should be applied. Preoperative evaluation, because most candidates for the ROS are under 50 years of age, it's not usually necessary to subject them to cardiac catheterization. CT angio is an excellent tool to evaluate the entire ascending aorta and arch, as well as the proximal coronary arteries. Cardiac MR imaging can be used as well, but doesn't give as much resolution as CT angio for the coronaries. Transthoracic echo gives excellent assessment of the aortic valve, ventricular function, and aortic root, but unfortunately, this modality cannot give a good or very detailed information regarding the pulmonary valve. Starting with the operative technique for ROS procedure, through the standard after the median sternotomy and aortic cannulation as distal as possible, with bicaval cannulation and initiation of a cardiopulmonary bypass. Systemic cooling is started, aortic is clamped, and initial antegrade and retrograde cold blood cardioplegia is given. We'll do transverse incision on the anterior aspect of the pulmonary artery, near from the origin of the right and left pulmonary artery, and extend the incision to either side with taking care to avoid injury to the left coronary. Then the pulmonary valve will be visualized. It must be a normal tri-leaflet valve, free from any diseases or abnormality. In case there is any evidence of the pulmonary valve disease, like a previous infected endocarditis, bicuspid valve, or perforation in the leaflet, we will keep the valve intact in the place, and the pulmonary artery opening will close by the 4O proline, and consider aortic valve replacement by other option, either homograft or any other appropriate prosthetic valve. After complete inspection of the pulmonary valve, we'll go to the aorta, and like showing in the picture, we do a transverse aortotomy and giving the cold cardioplegia directly in the ostium after removing of the aortic valve and the annulus is deprived. The left and right coronary ostia are both removed with the large button of the aortic wall, and the buttons are dissected free along the course of the coronary arteries to ensure full mobility, and special care to not injure the coronary arteries. Then going to the pulmonary artery and do dissection with the low current electrocauteries to freeing the pulmonary artery and its root from the root of the aorta down to the right ventricular muscles. In this area, we have to take care during the section to not injure the first septal artery and its complication to going through the septal infarction. Also, other point is important here to do hemostasis appropriately because maybe it's difficult to control the bleeding after the procedure is completed and aortic clamp removed. Then going for RVOT, we'll open the RVOT with 15 plate below the anterior commissure as determined by passing the right angle clamp 6 to 8 millimeter below the pulmonary valve annulus. You can see it in the picture, the distance between the right angle and between the pulmonary annulus. Then the incision is extended transversely across the RVOT, and the endocardium on the posterior aspect of the RVOT is incised with the knife 6 to 8 millimeter below the pulmonary valve annulus. Then going for suturing, after the pulmonary autograft is freed from the RVOT, we place it and from the excessive fatty tissue, we'll put it in the bowl of the blood, then do simple interrupted stitch 3O or 4O tacron suture placed at the level of the annulus. Then the aortic annulus suture passed through pulmonary autograft just below its annulus. The suture line should be begin at the commissure between the left and right coronary sinuses, and passing the needle inside, outside on the aortic annulus, and outside, onside on the pulmonary autograft. We can use the nerve hook to ensure the suture line is tight before tying the two ends of the suture. Then we'll do incision in the area of the planning implantation of the left coronary artery button using 4 millimeter punch would use to enlarge the opening. So the left main coronary button attached to the pulmonary autograft with the 5O continuous Prolene stitch, and then the right coronary button attached to the pulmonary autograft in same fashion. Then the pulmonary autograft will trim to meet the transected ascending aorta, and the distal anastomosis performed using 4O or 5O continuous Prolene stitch. Finally, the pulmonary homograft attached to the RVOT with the continuous 4O polyprolene stitch. Then the distal suture line is completed with continue 4O or 5O Prolene stitch. This is for root procedure. Then going for the second part of my lecture, which is aortic root replacement.
Dr. Agada, how long it will take from you the rest of, because now it's 2 o'clock, 1 hour, it's gone. The remaining, how long it will take?
About the valve sparing technique, I will not talk about it. Dr. Hammam will talk about it. So indication for aortic replacement, then I will go for aortic enlargement, aortic annulus enlargement. About 10 minutes.
About how much?
10 minutes.
Okay, go ahead.
Indication for aortic root replacement, the annular aortic ectasia or aneurysm of the sinus of the valsalva, which occur more frequency in non-coronary sinus than the right coronary sinus and less on the left coronary sinuses. In this patient, it may be possible to perform selective sinus replacement instead of the complete aortic replacement. Also, in case of the aortic root abscesses and stand 4 type A thoracic aortic dissection extending into the aortic root or small aortic root of root sparing technique are not possible. Here in summary, in case of the small annulus, we will do enlargement either by the posterior enlargement technique, which is Nix and Manoogian, or anterior enlargement by Kono, or replacement by Pental or Ross procedure. In case of the root aneurysm, we'll do replacement by Pental or valve sparing, remodeling or re-implanting technique. And the Stanford type A dissection will do replacement by Pental or valve sparing by remodeling and re-implantation. Here we have 2022 American Heart Association and American College of Cardiology guidelines regarding surgery for subprotic aneurysm of the aortic root and ascending aorta. And the class 1 patient with aneurysm in the aortic root and ascending aorta with symptoms attributable to the aneurysm, the surgery is indicated. Also in the class 1 asymptomatic patient with aneurysm in the aortic root and ascending aorta with maximum diameter more than or equal 5.5. Also in the class 1 patient with aneurysm in the ascending aorta or aortic root with diameter less than 5.5, but the growth rate in 2 consecutive years more than or equal 0.3, or in 1 year more than or equal 0.5. In the class 2A, asymptomatic patient with aneurysm in the aortic root or ascending aorta with maximum diameter more than or equal 5, surgery will be reasonable if performed with the experienced surgery with multidisciplinary aortic team. Also in class 2A, patient undergoing repair or replacement for tricuspid aortic valve who have concomitant aneurysm of the ascending aorta with the maximum diameter more than or equal 4.5. Also, if the diameter is more than or equal 5. Last indication in 2A, patient with height more than or equal 1. Patient with height more than 1 standard deviation above or below the mean who have asymptomatic aneurysm in the aortic root or ascending aorta with the maximum cross-sectional aortic area divided by height ratio is more than or equal 10. Now we finish from the class 2A. In the class 2B, patient undergoing cardiac surgery for indication other than aortic valve replacement or repair, the ascending aortic replacement with the maximum diameter more than or equal 5. The ascending aortic replacement may be reasonable. Finally, in class 2B, asymptomatic patient with aneurysm in the aortic root and aortic root or ascending aorta with the aortic sizing index of more than or equal 3.08 or the aortic height index more than or equal 3.2, the surgery may be reasonable. The operative choices for aortic root replacement, if the aortic root is dilated but the valve is structurally normal, we'll go through the valve sparing procedure, either remodeling, which is Yacob procedure technique, or re-implantation technique by David. Regarding the operative, Dr. Hammam in second lecture will talk about the operative for David and Yacob. Operative choices for aortic root replacement. If the aortic root is dilated and the aortic valve is diseased, we'll do aortic root and valve replacement by classic Pental procedure or modified Pental procedure. And modified in the classic Pental, we'll keep the aneurysmal aortic root. Then the coronary button is provided by hole within the prosthesis, but this technique nowadays not used. And the modified Pental procedure will excise the aneurysmal aortic root and the part of the ascending aorta, like in the picture B, then replaced after sizing in picture C, or replace the valve by valve conduit. And picture D, we see a re-implantation of the coronary button, and finally closure of the aorta. Final topic in my lecture is aortic annular enlargement. Talking about the posterior aortic root enlargement can be performed to allow for implantation of the larger sizer valve by either next procedure or Minogian. In the next, we extending the aortotomy posteriorly through the non-coronary sinuses across the aortic ring and inserting a patch to augment the annulus. In the Manugian, we extending the incision through the commissure between the left and non-coronary and into the anterior mitral leaflet. The result will increase, will do root enlargement by 10 to 25 millimeter, and the possibility of the implanting a valve up to 2 sizes larger than what the native annulus can be accumulated. For surgical technique, finally, in next and Manukian procedure, we can see the incision for next procedure through the toward the aortic annulus related to the middle of non-coronary cusp, then across the mitral annulus into the body of the anterior mitral leaflet, and also the Manukian incision between the left and non-commissure. We can see here in this picture the V-shaped dacron patch suture to the edge of this incision. Then after sizing of the valve and doing the usual stitching of the valve, we can see in the last picture the interrupted suture of the holding prosthesis passed circumferentially into the aortic annulus, except posteriorly, where the stitch will pass through the dacron patch. Finally, the outstanding part of the patch will complete and incorporate to facilitate the closure of the aortotomy. This is my lecture for today, and thank you for listening. Any question?
Yes. Thank you, Dr. Ghada. Sorry, I get disconnected for a short period of time. I don't know why. Very comprehensive and very informative lecture by you. Very well done. I like the illustration that you made and the pictures that you brought from the procedure and the illustration you made even in the charts. So any question for Dr. Ghada or comment by?
Thank you, Dr. Ghada. Could you just tell me the source of the pictures and information?
Well, I use a lot of sources. About the picture, I'm searching, but the source in the Lawrence, and I use other book, I forget. I will send it in the group regarding the operative techniques for Ross and subcoronary technique.
Thank you so much.
Welcome.
Okay, if there is no further question or comment, we can take just, let's say, 2 minutes until Ziad puts his presentation, so we can go in time. And thank you again, Dr. Ghada. Very well done. Dr. Ziad, are you here? You can share the screen and prepare your presentation. Yeah, go ahead, please.
Can we start now or after the 2 minutes?
No, go ahead. It's just
Okay.
1 minute past. Yeah, you can go.
Okay, thank you. Assalamu alaikum jami'an. My name is Ziad Sharif. I am R2 resident in Medical City in King Saud University in Riyadh. Today I will present to you the outcomes of aortic valve replacement. Is our objective. We will start with introduction. Next, we will talk about survival and symptoms improvement and quality of life. Then we'll talk about adverse event and geometry and function of left ventricle. After that, functional performance, independency, and cognitive disability. Finally, we'll compare between transcatheter versus surgical. At first, aortic stenosis is considered the most common type of valvular heart disease, and its prevalence is expected to double in the next 2 decades. There is no medical therapy to prevent the natural progression of the disease, but aortic valve replacement improves the survival and relieves the symptoms. Left unoperated patient who eventually become symptomatic and face a dismal prognosis of up to 50% mortality over the 2 years. American and European guidelines recommend aortic valve replacement in case of severe symptomatic aortic stenosis, with surgical aortic valve replacement being the standard approach for the patient with a low or intermediate surgical risk. Multiple studies have confirmed the beneficial effect of surgical choice on mortality, symptoms relief, and increased quality of life at subsequent follow-up. However, morbidity outcomes are less often reported. In this figure from one of the study, we can see the 3-year mortality percentage of patients referred with severe aortic valve stenosis for evaluation. The 3-year mortality after surgery was 10% compared to 48% in patients with medical therapy. Overall, 3 years survival after surgery was 90%, and 30-day mortality was less than 1%. Among unoperated individuals, the 3 years mortality was 48.4% up to 67.6% in high-risk patients. In comparing isolated surgical replacement with ones combined with bypass surgery, the 3-year mortality was not significantly different. At follow-up 1 year after surgery, symptoms were significantly decreased, with 75% and 46% of patients improving, but at least one class of New York Heart Association and the Canadian Cardiovascular Society, respectively. Self-perceived physical improved significantly in operated patient while remaining unchanged among unoperated patient. The proportion of operated patient experience a favorable composite of function and independency. Some things like living alone without minor or major assistance, functional in New York Heart Association Class 1, was increased significantly from baseline to follow-up, although this was only attainable for almost half of the patient. The changes in functional performance and cognitive disability from baseline to 1 year follow-up. The mean walking distance decreased from baseline to follow-up by 26 meters. Cognitive disability as defined by a cutoff of 25 point or less increased significantly when tested at follow-up.
Dr. Ziad?
Yes.
Yeah, I think some, I don't know whose mic is open.
Dig the tube behind the patient.
Really confusing.
Yes.
Dr. Anouf, yeah, thank you. Okay.
Thank you. In this table, we can see the improvement in New York Heart Association class and in the independency, while there is an increase in cognitive disability and decrease in the walking distance in the follow-up. The incidence rate for antibiotic requiring infection was 2-fold greater in the operated group versus the unoperated group. Conversely, the number of MI was lower among operated than unoperated patients. Rehospitalization within the 30 days of discharge occurred more often for operated than unoperated patient. However, for all hospitalization within the first year, the median length of stay was longer among unoperated than operated patient. Here we can see the most frequent adverse event among surgical patients is antibiotic required infection, while in unoperated patient, it was cardiac hospitalization. The result indicated that wall thickness were decreased and left ventricular ejection fracture increased for operated patient at follow-up. In contrast, no significant change in geometrical measurement or left ventricular ejection fracture were observed in an operated patient. In this table, you can see the improvement in the wall thickness and ejection fracture, while there is no significant change among an operated patient. Here you can see the improvement in New York Heart Association class in 75% of patient post-surgical replacement compared to 25% in unoperated patient and 46% compared to 9% in Canadian Cardiovascular Society. These some point worth to be mentioned. At first, long-term survival following aortic valve replacement among older patients is excellent, and therefore age should not be a factor for decision for surgery. The median survival times for aortic valve replacement group age group for 65 to 69 and 70 to 79 and 80 and over were 15.1, 10.6, and 6.3 years respectively. In combined surgery with bypass surgery for same ages group were 12.5, 9.6, and 6.4 years respectively. Second thing is the baseline CKD or severely impaired left ventricular function and current smoking state indicate particularly poor long-term prognosis. After surgical replacement, more than or equal 50% increased risk of long-term mortality. Third, the development of post-operation complications such as CVA, hemofiltration, or reexploration for bleeding reduced survival compared to patients who did not develop any complication. Fourth thing and last is that female survival advantage over men no longer exists in patients undergoing aortic valve surgery. In comparing between transcatheter versus surgical, still largely unknown due to high burden of comorbidity and advanced age. Transcatheter aortic valve implantation has emerged as an alternative to surgical replacement in treatment of severe aortic stenosis in high-risk surgical patients. The risk of conduction abnormality include left bundle branch block or the need of permanent pacemaker remain higher after transcatheter implantation than surgical replacement. Left ventricular ejection fracture was similar between transcatheter and surgical patient after 8 years of follow-up and the risk of all-cause mortality. The most frequent complication among transcatheter patient was requiring a new pacemaker, and among surgical patients was the new onset of atrial fibrillation. In another study, which was recent in late 2022, that compared transcatheter implantation with surgical replacement in low-risk patients, showed that there is no significant difference in the first 2 years, but after that time, surgical replacement associated with improved survival and 30% lower mortality. These are my reference. Thank you. This was in my presentation. If you have any question, please.
Thank you, Dr. Ziad. Any question for Dr. Ziad or comments? Okay, if there is no further question or comments, we can take like 10 minutes break to fresh our mind and take a deep breath. And then we'll continue, inshallah, with Dr. Hammam. He's gonna speak about aortic valve repair versus valve sparing. So we'll be back 2:30, inshallah. Thank you. Welcome back, everyone. So it's 2:30. Dr. Hammam, if you are ready, you can start.
Yeah, let's start, please.
Okay, just I want to make a notice. Please, everyone, be minded to mute his microphone. Okay, you can go ahead, Dr. Hammam.
So today we will go talk about repair of aortic valve and valve sparing operation. Let's start with introduction. We just talk about aortic root anatomy, reconstructive technique of aortic valve repair, indication for aortic valve sparing technique, valve sparing technique, advantage and disadvantage. So this is a picture of aortic root anatomy. The aortic root represents the outflow tract from the left ventricle, providing the supporting structure for the leaflet of aortic valve and form the bridge between the left ventricle and the ascending aorta. It extends from basal attachment of the leaflet within the left ventricular to sinotubular junction. So again, the aortic root consists of aortic annulus, aortic cusp, aortic sinus, and sinotubular junction. This is another picture of aortic valve annulus, just a cross-sectional picture. Aortic annulus has a muscular attachment. The muscular interventricular septum consists of 45%, and fibrous attachment consists of 55%. This is another picture just to show the relation between aortic root, aortic valve, and mitral leaflet and interventricular septum. This is another one, just show the relation between aortic cusp and relation to mitral valve and interventricular septum. So when we talk just about the reconstruction type, we have to just talk about the aortic valve repair type. So we have mainly three types. Type 1, they call them, it's considered for the functional aortic dilatation and cusp perforation, description in functional aortic dilatation, or aortic annular and sinus or root dilatation, surgical option, ascending aorta graft replacement, sinotubular junction remodeling, or aortic annuloplasty. For cusp perforation, we do just an batch repair or AVR. Type 2 aortic valve repair, in case of total prolapse of cusp or partial prolapse of cusp, we just use application, resuspension, or AVR. Type 3, consider for retraction with shortening of cusp, surgical option, shaving, or AVR. So in type 1 aortic valve regurg, aortic valve regurg with normal leaflet motion is rare and often amenable to the valve reconstruction. The technique varied depending on the lesion. In this case, in type 1, isolated aortic annular dilatation, it is rare. It may occur in dilated cardiomyopathy or rheumatic valvular disease, causing mild to moderate regurg, and may be associated with another mitral valve dysfunction. If the leaflet just display in minimal thickening or retraction, just a circular annuloplasty is carried out to ensure the adequate leaflet coaptation. So only annuloplasty, they're just doing an annuloplasty around the annulus in case of annular dilatation due to cardiomyopathy. In case of leaflet perforation, the defect is usually limited to a display in healed fibrous edge, like in picture A. In this condition, it's favorable for the valve reconstruction by patching using a glatteraldehyde treated autologous pericardium, like in picture B. The patch just apply on the perforating defect, adding a 2 millimeter margin for suturing. And then the suture to the edge of defect using 5 or 6 ohm monofilament interrupted suture. In case of big size perforation, better to use a continuous monofilament to decrease the effect of burst string. In case of small or pedicle vegetation, can usually be excised by scissor without production of perforation. A large perforation must be restricted and the valve repaired by patching. In all instances, the ventricular aspect of mitral valve should be carefully to detect the potential kissing lesion. In case of leaflet tear or effulsion, the most favorable lesion is tear in the belly of the leaflet that leave in commissural area intact, like in picture A here. This type of lesion is treated directly by suture and Teflon. Better just to do an interrupted suture just to make sure there is no sealing or regurg. Type 2 aortic valve regurg and type 2 aortic valve regurg can be constricted by reconstructed technique, particularly when the prolapse is limited and involve only one leaflet. Since the mechanism of prolapse is usually this distension for a free edge of the leaflet, the appropriate tension can be restored by triangular resection, same like in the mitral repair. In case of prolapse, they just do one triangular resection of the leaflet and they just take it by interrupted Rollin suture. Type 3 aortic regurg in case of restricted aortic valve. In this case, they just do a commissurotomy in the place where is the retraction is there. So only by the knife they just do an incision between commissure and remove the calcium plaques. So in patient with isolated sinotubular junction dilatation and well-preserved leaflet, supracoronary tube graft interposition is often sufficient to correct the aortic valve regurg. The goal of procedure is just to restore the normal ratio between circumference of sinotubular junction and the aortic annulus. In those patients with extended aortic root dilatation, aortic valve sparing procedures such as we will describe it like in Jacob and David just described by Dr. Agada before, better to be done in this case. So again, the valve sparing using reimplantation and remodeling technique, we will talk about it by detail. Indication of valve sparing in case of aortic root dilatation secondary to ascending aortic aneurysm. The mechanism of aortic insufficiency in this disease, state of consequence of dilatation of sinotubular junction with destruction at commissure of the valve leaflet. But the valve leaflet itself, it's normal. Second indication, annulo-aortic ectasia and connective tissue disease, such as Marfan and Ehlers-Danlos syndrome. The mechanism is dilatation of sinuses, the sinotubular junction, as well as the annulus due to the pathological cystic medial necrosis. The leaflet tend to be spared, and we can use either the David or Jacob technique. Third indication, aortic root and aortic dissection, even chronic or acute. If the patient with aortic dissection, but the valve is spared, we can use even the inclusion technique or reimplantation technique. In case also of aortic aneurysm, replacing of aortic root and ascending aorta, we can use the remodeling or reimplantation technique. So operative choices, if the aortic root is dilated, but the aortic valve is structurally normal, valve sparing procedure should be considered, even David or Jacob procedure. They called in Jacob technique, they called it a remodeling technique because they remodeling the sinotubular junction. And another option is David technique. Whether reimplantation technique or remodeling technique provide the optimum even from free survival. Let's talk about valve sparing for remodeling for Dr. Yaqub. The disease aortic sinuses are excised down to the aortic annulus, which is always healthy and can hold the suture securely even in patient with acute dissection. So they mainly they remove the sinuses, the aortic sinuses, and they just leave the commissure of leaflet and the leaflet. And they made in one of end of the graft graft tube. They made in 3 incision. The length of this longitudinal cut should be approximate 3/4 of diameter of the graft. Another end of tube, it will be rounded. So mainly it's one rounded end and another end, they just will do in 3 longitudinal incision. So this longitudinal incision can co-opt with a new commissure. So later on, the suture are passed from inside to outside of graft immediately and anchored to the end of the longitudinal cut, and then from the inside to outside of the remnant of aorta. The dacron graft is then sutured to the remnant of aortic sinus along the aortic annulus. Later on, the bottom of left and right coronary, they just re-implant. If the leaflet don't touch each other in the center, the graft may be too large. This can be corrected by swing the diameter of sinotubular junction. In case of leaflet co-opt excessively, they may prolapse under pressure. So the best method to be detected by Doppler echocardiography after discontinuation of cardiopulmonary bypass. So the last step in Jacob procedure is reimplant of left and right coronary. So it's simple, just they're remodeling the sinotubular junction. Another option is the David technique. For the correct size of appropriate dacron graft, commissure must be pulled up to create an virtuous cylindrical with cusp co-opt. Later on, after completion of the reimplant, the valve must appear in the means of trigonometry like in Mercedes stars. They take the sinuses and they bring the dacron graft and put the aortic leaflet inside the dacron graft without remodeling. So in the valve implantation, slightly pulling on the both commissure and the vascular graft before stitching the suture through the graft. The graft should be extended roughly by half of its maximum length at the segment, and insertion of saline allow the first judgment of leak-proofness of the valve. The reimplantation of partially restricted sinus valsalva start at nadir, 3 of the 3 coronary sinuses, each with double-armed monofilament suture going up to the both commissure where the suture were tied to each other. This suture line must be in hemostatic. Completion of the procedure, coronary ostia are reimplanted again in the graft using monofilament running suture. So the difference between them, just in case of remodeling or Jacob procedure, they remodeling the sinotubular junction. But in case of David procedure, they just put the dacron graft around the aortic valve, but both aortic leaflet, but both of them without coronary sinuses. So the difference between them, distentability of the annulus, positive for remodeling for Jacob procedure, cusp motion, positive for remodeling, valve stability, it's the same, sinotubular junction is the same, stability of aortic ventricular junction better in reimplantation. Aortic valve sparing operation in aortic root aneurysm, remodeling or reimplant. In total of 392 papers were found using the reported search criteria. From these, 14 papers were identified to have proved the best information comparing to the 2 valve sparing technique. No randomized control trials or meta-analysis were found. The total of 1,300 patients from 13 centers were included in this study. Operative technique was for Jacob it was 600 patients, and for David it was 700 patients. In early mortality, range 6.9 for Jacob technique and 6 for David technique. And the largest available series for 280 patients reported by David and colleagues in 2010. Early mortality was 1.6 in Jacob and was 1.7 in David group. A series of 30 patients with acute type A dissection managed with either Jacob or David technique, the overall mortality was 17. Cardiopulmonary bypass and aortic cross clamp time were longer or equal for David technique in all studies that reported this result. In several series, the freedom from moderate or severe aortic insufficiency within the follow-up period was more frequent for David technique. So that's mean the aortic regurg is more with Jacob than David. In conclusion of this study, in the largest available series reported by David and his colleague, the mortality was 1.6 for Jacob and 1.7 for David. Cardiopulmonary and aortic cross clamp time were longer for David technique. Freedom from moderate or severe aortic insufficiency within follow-up period was more frequent for David. Both approaches have not been associated with thromboembolic complication and the risk of valve endocarditis. In Marfan syndrome or acute aortic or acute type A aortic dissection and excessive annular dilatation may be benefit from David technique. The maximum systolic gradient measure in the reconstructed valve were essential physiological in all patients, favoring of David technique rather than Jacob technique in pathology such as Marfan and acute type A aortic dissection and excessive annular dilatation. So in conclusion, my aortic insufficiency, it was more with Jacob and more free with David technique. For Marfan and acute type A aortic dissection or excessive annular dilatation, better to use David technique. That's it. Thank you.
Did you finish, Dr. Amma?
Yeah, I'm finished already. Yes.
Okay, thank you for this informative lecture. You've done well. Any question for Dr. Hammam or comments?
I have a comment.
Please go ahead, Dr. Farid.
So from these two previous lectures, there are many techniques that have been described, but quite a few of them are historical and they are not practiced anymore, mainly because of the results and the outcome of those. And also, you have seen so many valves. There are more than 30 types of valves that has gone through the market, but you still see some valves that are used now more commonly than the others, and the others may have vanished even from the market. Pay attention to what you see in your practice and what you hear about different centers, how they do things, because I think that may be an eye-opener for you. And also, just like I said, be aware of the long-term outcomes. Some of the presenters have gave some references which may date a decade or two ago. And currently, the practice have changed dramatically with these aortic valve surgery and aortic root replacements. Thank you.
Thank you, Dr. Farid.
Thank you, Dr. Farid, for this input. Okay, if there is no further question, we'll take a break of 10 minutes, let's say, or just 15 minutes. We'll come back at 3:05, and then we'll resume, inshallah, with Dr. Mariam for the ischemia trial. Thank you. دكتورة مريم السلام عليكم.
Walaikum assalam.
الله يعطيك العافية. If you're ready, you can go ahead, please.
Excellent. All right, so we decided this week to discuss Journal Club. We selected ischemia trial, one of the very important trial that you guys all has to be aware of and understand with ischemia trial. But before we discuss ischemia, which is basically medical therapy versus PCI or revascularization in coronary artery disease, before we dig into this study, I'd like to start my presentation by a question. So in general, what are the indication of invasive angiography referral for patients with a stable ischemic heart disease? Or another way, if you have a patient with a stable ischemic heart disease who's recently diagnosed, would you refer him for cath or no? And if you would refer him to cath, do you refer all patients or a certain type or certain patients? Any clue? The audience? We have 40 participants, so anything? Do you know? Is there any indication, yes or no? Do we refer stable ischemic heart disease patient to cath in general?
Depending on the symptoms.
Okay, so patients having classical angina, right? So he would have chest pain and exertion that will relieved by nitro or by rest. So this is classical angina, right? And he was diagnosed by non-invasive test that he had an ischemia, like coronary artery disease. So what do you want to do now? Would you refer him for cath?
No, just follow up with the patient as
Okay.
outpatient. This is okay. Sorry about this. Okay. So usually in the hospital, what we do when I rotated with cardiologists, we just follow up. However, if the patient has any change in symptoms, or they have also the heart score. So basically, if the patient has any risk factors, old, diabetic, female, atypical chest pains, then yeah, that would be indication for cath, like emergency cath. But other than that, we just follow up.
So if they develop symptoms or their symptoms has progressed, that means by definition, this patient is now having an unstable angina, which is considered to be acute coronary syndrome. So this is, in itself, it's an indication for cath, because the patient now defined or diagnosed with acute coronary syndrome, but not stable ischemic heart disease. But if you have patient with stable, he's having chest pain, very controlled chest pain, relieved by nitro, you did non-invasive tests, for example, treadmill, ECG exercise, or echo, or whatever, and it's confirmed the diagnosis. The only indication to refer for angiogram is as a follow. 1 second. So one, if the patient has a large ischemia and a non-invasive test, so they will modify it according to the territory, small, medium, intermediate, or large ischemia and non-invasive test. If the patient has stable ischemic heart disease but very large ischemia, most of the cardiologists would send the patient for cath. Okay, if the patient has stable coronary artery disease but heart failure symptoms with significant reduced ejection fraction, they would be sent usually for cath. If the patient has inconclusive results on non-invasive test, or patient has any contraindication to non-invasive test, so you can't actually perform non-invasive, and there is a high concerns of coronary artery disease, then you would refer him for cath. The last one is if the patient has a stable ischemic heart disease with moderate risk of ischemia and non-invasive, but the patient is unsatisfied with the quality of life, or the symptoms, like he would say, I don't want to continue having nitro every time I have chest pain. Okay, or by other mean that he's in optimal medical therapy, but it still is not controlled, his symptoms not controlled, then you would refer him for cath. Okay, so this is just to keep in your mind that there's actually no strong evidence of refer a patient for cath or PCI in the setting of stable ischemic heart disease. Now, my second question is, are you aware of any evidence or like trials that have tested or compare PCI versus medical therapy in a stable ischemic heart disease before ischemia trial? So if we say there is no, there is no certain, or like, for example, a clear indication or strong evidence to refer patient for cath, that means we must have a trials or a study that has actually showed no difference or equivalent of medical therapy versus PCI in a stable ischemic heart disease. So anyone can recall any of the important trial?
Syntax.
Syntax compared PCI versus CABG.
I think you mean the Courage trial.
What is it called?
Courage trial.
Yes, excellent. Who is this?
This is Dr. Abdurrahman Roueli.
Okay, so thank you, Abdurrahman. So yes, the most important, there's a lot before the Courage trial, there was a lot of very old studies that was done in the 80s and early 90s, very small studies, not very well done, a randomized patient to PCI versus medical therapy in a stable ischemic heart disease. However, they are unreliable right nowadays, because back on the days, although studies been criticized right now, that patients were not medically optimized at that time. And the PCI that was done in the 80s and the 90s, they were using bare metal stent or just ballooning the vessel without a drug-eluting stent. So they said, we can't rely on that result, or we can't say there is no difference between PCI versus medical therapy, because those studies were not done or were done in an old era. Okay, so they were very encouraged to do the Courage trial. The Courage trial was done or published in 2007 in New England Journal of Medicine. They compare patients with stable coronary artery disease, optimal medical therapy, with or without PCI. So every patient was medically optimized, and then they randomized them to PCI versus no PCI. Okay. And at this study, they were hoping that it's going to be a positive study, given the fact that all patients were medically optimized, and those who had a PCI had received a drug-eluting stent. So their claim that PCI was not valid in the previous study because it wasn't drug-eluting. Now they use drug-eluting stent, and they compare medical therapy versus PCI in a patient who was stable. And the conclusion was PCI did not reduce risk of death, did not reduce MI, did not reduce other major cardiovascular events when added to medical therapy. Okay, and this was in 2007. Since 2007, I think 2010, they were trying to do another trial. They were not very convinced. They said, okay, maybe those patients are not very selectively. So we're gonna do a study called the Barry 2D trial. Barry 2D, they compare, again, patients with a stable coronary artery disease, medical therapy versus PCI, but all patients were diabetic. And their claim that diabetic patients are special, and they would likely benefit from PCI. Okay, but again, I don't have it here in my slide, but the conclusion was same. No difference. PCI did not reduce risk of death, MI, or any major cardiovascular event, even in patient who is diabetic. Okay, so and then since 2010, there was silence. So patient will be referred to cath only If we have we know that the patient may have left main or have very significant ischemia on non-invasive tests. Otherwise, they will only be medically treated, okay? And refer to cath if they have any change in their clinical status. Okay, more recently, in 2021, they also did a meta-analysis to compare PCI versus medical therapy, again, for patients stable coronary artery disease. Same conclusion, no all-cause mortality was not significant different between PCI and medical therapy, okay? Now they came up with the ischemia trial. They said, okay, now we are in, ischemia was published in 2018 or 19. So they said nowadays we have better medical treatment, so patient will be more medically optimized with PCI or drug-eluting stent, but also we're gonna highly select the patient who we think they may benefit from the PCI, which is patients who have moderate or severe myocardial ischemia and non-invasive stress test. They said in the COURAGE trial, they were just like randomizing all patients with stable coronary artery disease. So here we're gonna select the patient who may think they may benefit from the PCI. And they said, okay, let's go ahead and do it. So they did. How did they do that? And their goal was to evaluate routine invasive therapy compared to medical therapy among patients with a stable ischemic heart disease with moderate to severe myocardial ischemia on a non-invasive stress test, okay? So the study design was randomized. Patient with all patients with a stable ischemic heart disease, all of them have to have or have to undergo a non-invasive stress test. Any type of stress test, could be treadmill exercise, could be a nuclear, it could be echocardiogram, any non-invasive stress test to evaluate the extent of ischemia. And if they have moderate to severe ischemia, those patients will be randomized to routine invasive versus medical therapy. And I mean by invasive, that means patient will be medically optimized and will send for cath. So they will undergo angiogram as a routine. And then depend on the result of the angiogram, they will be treated accordingly. If they need, if there's an indication for stenting, they will do. And if there is an extensive coronary artery disease and they think the patient may benefit from CABG, they will refer to CABG, okay? The other arms will be a routine medical therapy only. They will only be sent to cath lab if they failed medical therapy, okay? So they have enrolled 5,000 patients, and the mean duration was 3 years, and the mean patient age was 64, which is typical for patients with coronary artery disease. Almost half of them have diabetes, and only 20% were female. I forgot to mention that the COURAGE trial, they extended the follow-up up to 12 years. 12 years, and they did not show any difference, even in long terms, between medical therapy versus PCI. Okay, here in the ischemia, it was only for the median follow-up was 3 years. Okay, as an inclusion criteria, I tried to make it as simple as possible and make it as a story so you guys can memorize the story behind the ischemia. Okay. So the inclusion criteria, as we said, moderate to severe ischemia is defined in non-invasive tests, stress tests. So if it's nuclear study, they have to have at least 10% of the left ventricular ischemia, okay? If it's stress echo, they have to have at least more than 3 segments with stress-induced moderate to severe hypokinesis or akinesis. If it's CMR with perfusion, they have to have at least 12% myocardial ischemia or wall motion abnormality, 3 out of 16 segment with a stress-induced severe hypokinesis or akinesis. If they do exercise tolerance test, so they have to have more than 1.5 millimeter ST depression and more than 2 lead, or 2 millimeter ST depression in a single. Okay, and with the significant or the intensity of the stress test, it has to be positive in less than 7 minutes. Okay, and positive for angina. Okay, as an exclusion criteria, they were very fair. Any patient who were severely symptomatic, meaning having NYHA class 3 to 4, they were excluded. So they want really those who are stable. Okay, if the patient has unacceptable angina despite medical therapy, we're excluded. And by definition, they're not stable. If they're still having angina despite medical therapy, they're not stable ischemic heart disease. They're unstable angina or non-ST signal elevation myocardial infarction. So there were acute coronary syndrome. They were excluded from the trial. If the patient has significant decreased ejection fraction, meaning less than 35%, they were excluded. But not only normal ejection fraction, so 35 and above were included. Patients with acute coronary syndrome within the last 2 months were excluded. So if you have acute coronary syndrome, for example, 3 months ago, but now you're stable, so it has been managed, your acute coronary syndrome has been managed, and now we have converted you from acute coronary syndrome to stable ischemic heart disease, it's okay to be enrolled, otherwise no. Okay, if the patient has a PCI or coronary bypass within 1 year, they will be excluded. And at least, and last things, were a patient with a chronic kidney disease or who had a GFR less than 30 ml, or patient in dialysis were excluded. But they're still interested in this type of population. But just to make your life more difficult, they are conducting a new study called ischemia CKD. So ischemia of the chronic kidney disease patient. Excuse me. And then, so patient with left main disease were excluded from the trial. And in order to do this, they sent the patient, after they confirm the diagnosis, to a CTA to check for their eligibility criteria. So there will be eligible if they have more than 50% stenosis in any of the major epicardial disease, but not left main, or more than 70% stenosis in a proximal or mid-vessel disease. Okay. If the patient has 50% stenosis and unprotected left main disease, they will be excluded from the study. Okay, the primary outcomes, they looked into the composite of cardiovascular death, so cardiac-related death, MI, resuscitated cardiac arrest, so the patient had any cardiac arrest or hospitalization of unstable angina, or heart failure at 3 years follow-up. They noticed no difference, 13 versus 15% p-value is not significant between those who had invasive versus optimal medical therapy alone. Secondary outcomes, they said, okay, we're gonna make it a little bit more simple. So we're only gonna look into myocardial infarction and all-cause mortality as a secondary outcomes. And again, as you can see in the table, p-value is not significant. Death or myocardial infarction between invasive group versus medical therapy. And again, when they looked into all-cause mortality in specific, it was 6.4 versus 6.5, no significant difference between invasive versus medical therapy. This is the graph, and you can see how they are running identical, conservative versus invasive. Okay, this is a very important piece of information that was thrown in the method within the paper. Among patients in invasive strategy, 96% underwent angiogram. So it's not all of them. Although they were routinely assigned to go for CAF, There's 4% of them, they did not underwent CAP, but 96, which is a good percentage, they underwent CAP, okay? 79% of those who underwent CAP had or underwent revascularization. And when we split up the revascularization, we can notice that 74% majority had a PCI and only 20% had CABG. Okay, and keep this information in your mind that yes, this study or ischemia did not compare between PCI versus CABG. However, it is medical therapy versus revascularization in general. But the majority of the revascularization method that was used in this study, it was PCI, 74%. Okay, very little or a few patients underwent CABG or referred for CABG. The study limitation, it was unblinded trial, as we know, those patients who want invasive or conservative therapy, they were aware. Not applicable to patients with reduced ejection fraction less than 35%. Okay, so keep in mind, if you have patients with reduced ejection fraction less than 35%, you can't apply the conclusion of this trial on this patient. Patient who had left main disease, again, they were not part of this trial. Patients who are very symptomatic were excluded as well. Same things for patients with acute coronary syndrome. One of the limitation as well, it was only 20% female enrolled in this trial. So as an overall, this trial was negative to compare invasive versus conservative treatment in patients with ischemic heart disease. There were mixed findings with the evidence of both harm and benefit. I'm gonna read this for you and then we're gonna analyze it together. So there's significant durable, and they said the significant durable improvement in angina control and quality of life with an invasive strategy if they had angina occurring daily, weekly, or monthly. So they did a sub-analysis for patients, and they noticed those who have a very significant angina happening in a weekly or daily, or weekly, who had underwent PCI, they have a better quality of life compared to those who had no PCI. However, in patients without angina, an invasive strategy led to a minimal symptoms improvement or quality of life benefits as compared to a conservative strategy. An early invasive strategy in general was not associated with significant reduction in any of the clinical events that was tested in this trial. Okay. Now, that's all about the ischemia trial, and we all know about this since 2019. Okay, and we know that this is ischemia, compare medical therapy versus revascularization or routine PCI, and there is no difference. And then 2021 coronary guidelines came out, and surprisingly, they downgrade patients with multiple coronary artery disease. If they compare PCI versus CABG, they downgrade CABG to 2B from a class 1 indication, as you can see here. So if you have normal ejection fraction, triple vessel disease, it is 2B and 2B if you for either revascularization, either PCI or CABG. And we were in shock for this, and we discussed this with you guys before. So we went into the guidelines. So each recommendation has to be explained, okay, in the guidelines. So when you go back and you see the explanation, this is their explanation. They would say ischemia trial showed no difference in the rate event with either CABG or PCI over medical therapy when patient has multiple coronary artery disease involving proximal LAD. This is their justification to downgrade a patient with triple or multiple coronary artery disease and to equivalent PCI versus CABG according to the ischemia trial. So what we can say to them, this trial was not powered to compare PCI versus CABG. Syntax was, okay? Yet they did not mention anything about syntax. They did not refer to syntax trial when they decided to downgrade the recommendation. So when they put this comment on the guidelines and refer to this does not make any sense. An ischemia trial, there was no, it shows no evidence or no benefit of PCI because majority of patients underwent PCI as compared to medical therapy. But you can't comment on CABG because only 20% of patients underwent CABG in this trial. And it's not fair comparison between the two modality of the revascularization. It was a comparison between medical therapy versus revascularization in general. Okay? If you go back to the ischemia conclusion in the article itself, their conclusion, this is not my own words, but in the paper, they said, we did not find evidence that the initial invasive strategy, we didn't find evidence that the initial invasive strategy reduced the risk of ischemic cardiovascular event or death from any cause. So it was a negative study in their conclusion, and they did not mention anything about CABG or PCI. It's just like general about invasive strategy versus medical therapy. But yet they have to modify their conclusion in the guidelines. Okay, so that's all my presentation. I tried to keep it very short so you guys can understand it. I didn't put a lot of information, but I put the most important information that you guys would have to face these days. You have to understand what's the comment from the guidelines and how would you be able to defend yourself by saying this is actually not related and this is not the conclusion of the ischemia trials and is not powered to compare PCI versus CABG. Any questions?
Yes, doctor, I have a question.
Yes, go
ahead. The only thing they downgraded is CABG, although the majority of patients underwent PCI. So why?
Yeah, that's what I'm telling you. It doesn't make any sense. Even when you try to go and see why they downgrade the PCI, they're referring to the ischemia trial. And this is what they're saying. Because of the ischemia, they said ischemia did not show any difference between CABG and PCI versus over medical therapy in patients with multivessel coronary artery disease. This is not what the ischemia trial showed. So this is wrong. This statement is wrong. Ischemia trial shows no difference between invasive, general revascularization versus medical therapy. And if you want to refer to the method of revascularization, you have to tell them that 79% of the revascularization and almost 80% was PCI, stenting. Only 20% had CABG. So number one, it was not powered to compare PCI versus CABG. Number two, if you would want to refer to this point, it makes more sense if you would say medical therapy versus PCI. That's not medical therapy versus CABG. The guidelines for multiple coronary artery disease and a stable ischemic heart disease with PCI, it was 2B and it's still 2B. They did not change it, but they downgrade the CABG unfairly.
Yeah, that's clear. They should have downgraded both at least.
Yeah, I mean, they can't downgrade PCI less than 2B because there is some evidence that it's, sometimes it's effective. So less than 2B, it's going to be harm, right? Going to be 3 or no benefit. So they could not reduce it less than that, but they downgrade CABG from 1 to 2B. They did not even do it to A. They did it from 1 to 2B. and they're referring to the ischemia in their text of explanation.
Yeah, that's clear. Thank you, Doc.
Yeah. Any other questions?
Assalamu alaikum.
Alaikum salam.
Dr. Mariam, I have one question.
Yes.
What if someone argues that this study is merely comparing revascularization, regardless of the mean, whether it's PCI or not? Revascularization, like resuming blood supply to the heart, showed no benefit in terms of patient outcome compared to medical therapy in those patients.
Yes.
What is the reply or the argument against such an argument?
I would agree. It's true. This studies, it's compare medical therapy versus general revascularization, okay? And it shows no difference. If patient has stable ischemic heart disease, if he's on optimal medical therapy versus if you would do stenting to him, no difference. And mortality, no difference in MI, no difference in cardiac related death, nothing, okay? But if you would come to me and now that they have like crossed the red line and they said, no, we're downgrading the CABG because now they're referring the CABG to the revascularization method that they were used in the study. And they said, okay, since there is no difference between medical therapy versus CABG and a patient with stable ischemic heart disease, so then why would we refer a patient for surgery? So you would reply back to them and say, what is the percentage of the patient underwent CABG in ischemia trial? It's only 20% compared to 80% PCI.
But if we take it like on its basis, revascularization in general was not helpful in those patients.
Correct.
Why would CABG be any different? Is there any evidence that CABG is different than PCI?
No, in patients with stable ischemic heart disease, there is no benefit for CABG, no benefit for PCI, no benefit for nothing, only medical therapy.
So why was it class 1 before?
A class 1 before, according to the angiographic criteria. So if they have 3 vessel disease, specifically, if they have left main, if they have 2+ proximal LAD, according to the previous study, when they compare CABG versus medical therapy alone, do you remember the CAS trial, the very old CAS trial, the VA trial, there's Yusuf meta-analysis studies, they all show significant improvement or significant benefit of CABG over medical therapy.
I see, but these were
so we do have evidence. We do have evidence that patients with stable ischemic heart disease, if you would do medical therapy or you do CABG, those who had underwent CABG in a certain, certain criteria, patient would do better. They will have a better survival. But if you would compare medical therapy to PCI, no difference.
But the studies that support CABG in stable coronary artery disease against medical treatment, like the CAS and the veterinary affairs, these are very old. I think medical treatment has improved significantly since then. Do you think maybe if we do a study separate only for CABG against medical therapy in those patients in the ischemia trial, maybe we would reach the same conclusion as they reached for the PCI?
That there is no difference between CABG versus medical therapy in stable ischemic heart disease patients?
Yes.
Yeah, I mean, you can. Nobody would do this because they have not the margin of difference between it's very significant. So they would say, even if you would put the patient on medical therapy, they will still. But they test this also for when they compare CABG versus PCI in the syntax, right? Because by definition, all patients in syntax were medically optimized. So you compare CABG, like coronary bypass revascularization, versus only stenting, and there was significant difference or improvement in CABG versus PCI. So you would expect, if you downgrade the treatment to medical therapy versus surgery, there will be a huge difference as well.
Yeah,
you get my point?
Yeah, I just to add that if we look at the ischemia participants, they were way younger and less likely to have hypertension, diabetes, previous stroke, peripheral vascular diseases. So the patient, they had a better LV function and less extensive coronary artery disease. So of course there will be no significant between the medical and the PCI or the CABG.
Yeah, they're highly selective, very huge,
Yeah,
they're very, you know,
they were
healthy patients.
selected.
Yeah.
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 So of course
But
there
they
will
have
be there's no-
significant, but they have significant ischemia. They have significant ischemia in non-invasive tests, right?
Yeah.
So they thought it's going to actually be a positive study, and we would, they will be able to prove that early revascularization or invasive or sending patient to cath would have a survival benefit over medical therapy alone. But it did
Yeah.
not.
Yeah.
Okay, so that in general, again, I emphasize how they unfairly use the ischemia trial to downgrade the coronary artery disease. And this is their actual conclusion or the comment on the guidelines, which is like, it did not come into line with the conclusion from the ischemia trial. It's completely different.
So the ischemia trial, if I would summarize its conclusion, that in patients with good LV function, who do not have renal disease and have significant stable coronary artery disease, revascularization with PCI is equal to medical treatment.
Correct.
Okay.
Or CABG
Okay,
even.
so yeah, so but you can't say CABG per se, but it's for PCI athletes because 80% under 1.
Yeah, the participant for the PCI
Yes.
way more than the CABG, but
Yeah.
So,
So they were the cardiologists trying to recruit more patients for PCI, more patients sent for cath lab. And you have to understand it's different practice than here in Saudi Arabia. For those who's going to go do fellowship abroad, the medicine practice there, it's fee by service. So the more procedure you do, the more you're going to get paid. So there's a lot of bias there in US and Canada, and even maybe in Europe, I'm not sure, that they would want to send those patients for cath lab, even if they are stable, so they will convince the patient, we're just going to look and see your coronary, right? Because if they do that, they will get paid. If they only send patients for medical therapy, it's less paid, right? So interventional cardiologists are trying to recruit more patients into their practice by trying to conduct this study to convince that there is actually a benefit of doing early invasive and cath lab for all patients with coronary artery disease. That's what they're actually trying to. They want any patient who has been recently diagnosed with coronary artery disease, he has to be sent for cath, and then based on the result, we will decide whether to treat or not to treat. But the evidence did not support what they want.
well, thank you so much, Dr. Mariam.
Any other questions? So what I want you guys to try to understand what is the background. Why did they do the ischemia trial? So that's why I tried to start telling you about the COURAGE trial, the BERRY 2B, how did they did not find any evidence for PCI, but they tried to convince themselves and looking at the exclusion criteria for those study and try to involve them in their study. So they said if they have randomized all patients with coronary artery disease, but we will be very selective and randomize only patients with moderate to severe ischemia. And we think those population will benefit from revascularization. They criticized the old study by, which is true, which is valid, that it was done, or the PCI was done with bare metal, not drug-eluting stent. So they're trying to restudy all the patients with drug-eluting stent, hoping for better outcomes. Any questions?
Thank you so much, Dr. Mariam.
Those who's gonna write their exam this year, now you know. what's ischemia trial, and how would you defend your answer about the downgrade of the coronary artery disease? It's not PCI versus CABG. It's medical therapy versus revascularization. Okay, I wish you guys all the best.
Thank you, Dr. Mariam. يعطيك العافية. Any questions or comments, guys? Okay, if no, I think this will conclude our session for today. Thank you all.
Thank you.